Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box sets curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts. You're thinking, but I've never read about these midwives in the Bible, and that's because they didn't make it into the Gospels. Why was it that we nurses, midwives, seem so invisible to the doctors, to the media?
An amazing midwife said to me, you can't be what you haven't seen. These are the world's most researched probiotic, and we can say that with confidence because we've done over 300 clinical trials on this little bottle of goodness. These
And welcome everyone to this week's Maternity and Midwifery Hour. This is now Series 19. I can't believe Series 19. And this is Session 1. My name is Sue MacDonald and I'm the curator for the Maternity and Midwifery Festivals and also the Maternity and Midwifery Hours. And it's my delight to be chairing this evening's session, which I know you're going to really enjoy. It's going to be all on antenatal care, and it's going to really challenge, make you think a bit differently, which is our main aim on these hours. And I'm delighted to be joined by Anna Melamed, and I'm sure I've pronounced it incorrectly again, Anna. I'm so sorry. My tongue doesn't seem to want to do what it has to do. So welcome. Now, we always ask our guests to share a moment of the week, and I know Anna's got a delicious moment to share with us. So please share away and welcome.
Hi. Hello, everyone. Really happy to be here. My moment of the week, I had one prepared, and then in fact today I'm a midwifery lecturer at University of West of England in Bristol, and a student emailed me and said, have I seen this and do I want to go and can I give it a plug? So it's, the plug is for the 5th of May, which is International Day of the Midwife, and the students are doing a protest in Westminster in London at 4:30 to talk about the problem of the student midwives not getting jobs, whereas we know that women are, desperate for more midwifery care. So please go if you can. But I was also really it was quite a moving moment of the week because I was really pleased to see the next generation of student midwives kind of taking action and feeling empowered to go and have their voice heard. And I was pleased that she reached out to me and felt she could do that and asked me to mention it this evening. So it's both a plug and a moment of the week.
Fabulous, fabulous. Well, you can shout out the student's name.
It's Amy. Well done, Amy Peach.
Hi, Amy. I think this is fantastic, and and so much, and thank you so much for raising it. We did have a group of students coming in at the last London event, and I think we were very. I mean, I was certainly stunned when they were talking about the numbers of like 3 jobs in the whole of England that were on offer for all the students, and it's very shocking. So I just a little note to people who are watching this evening is on the resources sheet there should be a link to the petition, and it's if you want to go in there and sign your name, it doesn't commit you to anything, but it does make sure that the numbers go up, and it will be something that will be discussed a little wider, which would be fantastic. So thank you for sharing that, Anna. Now I'm just going to let Anna have a little rest and just welcome everybody again. Now, I know there's going to be people here are brand new to the Maternity Midwifery Hour, and there are some old friends with us, so welcome to both. And I always like to say, and I think it's especially because now it's 6 years since we started this, and we started right at the beginning of the first COVID UK lockdown. Because if you remember, and if you were practicing at that time, you will know very well, everything was very much focused on the clinical side and the education side, and therefore midwives and student midwives had to not have face-to-face conferences and study days. And we really felt people needed something. They needed information, they needed knowledge and continuing professional development. So we started the hour. And initially we started with a lot about COVID and how different services were coping with it. It was especially interesting, I found, how creative and how committed our midwives were to making sure women and babies were getting their care, and the adaptations that had to be made, which were very difficult for midwives and also for students, and also, of course, mothers and their families at a very important time in their life. But I think I always sort of think I want to give everyone a pat on the back for all that they did at that time. And every Wednesday, I do remember the COVID thing and having to queue up and having the masks. I've got a whole drawer full of blooming masks still, and I won't throw them away because you never know. But one of the lovely things has been the Maternity and Midwifery Hour, and so welcome to this. We don't do so much on COVID now. We're really talking about things that are of importance to midwives and student midwives, mums as well. We do have some mums that come along, and also some doctors, some paediatricians and some obstetricians that come in from time to time, which is also really good. I also must say, if you get a power cut, don't panic. Everything on the Maternity and Midwifery Forum is recorded. So if you should have a power cut, and one of our speakers once had their broadband cable bitten through by a mouse, true story, you can catch up later. That's the point I'm trying to make, not very well tonight. And also, the other thing you can get into is Matflix, and again, that's on the list of resources. So you can actually see all the sort of, well, you might take some time going through all of the video clips and presentations we have on the back issues. We've got a lot, but this is fabulous if you're doing a project, or if you're doing dissertation or anything, any academic work, or if you want to do some practice development work and improve something. This is a good place to get lots of information. And I know a lot of the maternity units and a lot of the universities are signed into Matflix. And if your university and your unit aren't, ask why it's not. And if you want to get a subscription, it's the price of a couple of cups of coffee a month, so it's not any big deal. Anyway, so do feel free after this evening to share. You'll get a link back to this hour, and you can share with your colleagues, and you will learn things. And I always think it's useful to talk about things you've learned and you've heard and to discuss it. We're very good at that generally as midwives, so get into doing that and share. We're very keen on you doing that. Now, moving swiftly on, today is Earth Day. And I think it's important we spend a few moments to talk and think about appreciating things that we take for granted, like the oceans around that keep our planet going, the land, the creatures that are around, and think about how we as individuals, as a group, and I think sometimes the human race are not doing very well on this, but I think as individuals we can change things and we can make things better, and we can reduce the amount of plastic we use and try and recycle where we can. I always think of this when I go to my recycling unit every weekend with my paper to recycle, and I see people chucking away things and thinking, why don't you take it to the charity shop? Because that's one man's rubbish is another man's treasure, or another woman's, I should say. I think we're better at it. Anyway, so that's me. I'm getting off my soapbox now. It's also World Admin Day. There's a day for everything in this world. And I think it's important actually to celebrate the administrators that work within the NHS, particularly in the UK, because they get a lot of stick. You know, there's always things on, you know, when people are trying to cut costs, they'll say, oh, we're getting rid of admin and managers. Actually, if we didn't have admin and managers, we'd be in trouble because we'd have to do a lot less caring and a lot more of that stuff ourselves. So let's celebrate them. Yes, for admins. Also, today or this week actually is Black Maternal Mental Health Awareness Week, and that's from the 20th to 26th of April. It's been led by the 5 Times More group, and that's also in the resources. Fantastic website they do have. You can't forget, and we mustn't forget, that Black women are still 2.3 times more likely to die in pregnancy and childbirth, and Black babies are more likely to be stillborn than white babies, and we need to address that seriously. And check out the resources, because on the 5 Times More website there's a really good report that really gives you that information. It's a real huge range of information. And I'm almost perfect on timing. So now I'm moving swiftly into our presentation for this evening, and we're going to be looking at antenatal care, something we take for granted. We've been doing it for years. Of course, we know what we're doing. You can wonder why some women don't always come up for their antenatal care, but that's another story. But it has become more complex, just as women in our maternity services and their babies have become more complex. How can we get it right? Now, I'm really thrilled. We've got Anna Melamed, and I've pronounced it wrong, I'm sure again, Melamed, who's a registered midwife and midwifery lecturer based in Bristol. She's practiced as a midwife in London and Bristol, and most recently in community settings. She's currently teaching on the pre-reg programme at the University of the West of England. She's got a master's in global maternal health from City University in London. She's researched and written on increasing equitable access to midwife-led birth settings and feminist analysis of midwifery care, and she's currently researching antenatal risk assessment, which is why she's with us this evening. So welcome, Anna. The screen is now yours. Thank you so much for coming this evening, and we're looking forward to hearing the words of wisdom you have.
Lovely. Thanks so much. Thanks for inviting me. It's really nice to be here. Yeah, I'm Anna Melamed. Like I said, I'm currently working as a midwifery lecturer and researching antenatal risk assessment and classification. So what I'm mostly talking about is a integrative literature review that we have published, that I headed up with a really great team, and that got published in Midwifery this year. So to sort of start, sorry, just working out my slides, yeah. So to sort of start by really zooming out and kind of having a think, why do we actually perform antenatal risk assessments? Well, the rationale is, if we know more and we know it sooner, we can do something about it that will improve outcomes. That is a kind of criteria also for screening programs, which are slightly different from risk assessments. They have a more sort of particular definition. But, you know, there has to be an idea that we want to find this out. We want to find it out in a timely manner so that we can improve outcomes. There has to be a reason for doing the tests. One of the pieces of literature that we looked at defined it like this: risk assessment is screening for conditions that could result in adverse perinatal outcomes for which an intervention would improve the health outcome for the mother or child. So the value of any risk assessment is also dependent on the action that can be taken and the benefits of that action. So at the moment, what we do is we classify women, we classify pregnancies, by risk. So we tend to have a low risk, intermediate risk, or high risk, or some trusts would call it complex care. But women are classified in such a way that they're either in midwife-led care or they're in obstetric-led care. So it impacts on the lead professional, it impacts on the care pathways. For example, are they recommended extra scans? Are they recommended an induction of labour at a certain point? And it also has a really big impact on their birth settings. So we tend to say midwife-led birth settings, so the birth centres or home births, are suitable for low-risk women. So if you become a category that is no longer a low-risk category, then that has an impact on the birth settings that are recommended. We estimate that about 15 to 18% of women in England give birth in midwife-led settings. Got a feeling in some trusts it might be even lower. So this risk classification is obviously having a really big impact on that, although not only, obviously, there's things like choosing to have an epidural, which also put you in an obstetric setting. Just a note on the references, actually. Where I've referenced, it's often because it's something that's come out subsequent to our work or it wasn't included in our work. So the reference list at the end isn't, if you want all the references, it's in the paper that I'm talking about, but there's some additional ones like that Rivers one. So what does policy do? Well, mostly when we've tried to look at improving outcomes, initiatives like the Saving Babies' Lives tend to focus on increased surveillance and increased intervention as a reaction to when we've found risk categories. So that's been the tendency over the past particularly 5 or 10 years. So let's have a little kind of think, is that working? Now, these graphs are a little bit, I've done it for sort of dramatic effect. They're not completely the same thing. The one on the left is the births. So this is the figures I'm sure we're all very familiar with of the spontaneous vaginal birth rate going down, the caesarean section rate going up, and the induction of labour rate going up. And I think that's something I'm sure everyone on this call will recognise those rates. So that is as a percentage of delivery is the left-hand chart. Now the right-hand chart I've done slightly sort of laid out slightly differently so that we can see the lines. So that is the neonatal outcomes are per 1,000 and the maternal outcomes are per written 100,000. I think it's 10,000 actually. I think I've made an error on my slides. Anyhow, you have got your yes, it's 10,000. I made an error. So the stillbirth rate is coming down. You know, that's good. There's been a massive government initiative to try and bring that stillbirth rate down, and it is coming down. Not as much as the government targets were, and not as much as we would hope, and not as much as if you compare it to the left-hand chart of the amount of interventions we're doing. However, we also see the neonatal death rate going up slightly. And there, the figures are there. So we see that, and I talk about that a little bit as to why that might be. But the other really significant figure I want to point out here is that the maternal mortality rate for direct causes is going up. So we had 2012, we had 3.7 direct cause maternal deaths out of 10,000. And in 2023, it's 5.9. That's that, and it actually down from a high of 6.2 in 2021. So that is really kind of notable. Obviously, the numbers are still very small, thankfully. We're very good at our maternity care in the UK, but I think I come on to talking a little bit about why we might be seeing those figures. We've got, for example, it's been in the news recently, things like the rise of placenta accreta. I also do want to mention that the stillbirth rate is not coming down for Black and brown babies. So we might say that something about what we're doing about that risk assessment and those care pathways and then those interventions is not having the effect that we had hoped it would have compared to the amount of interventions. And the other thing I've just written there is not everything that counts can be counted. Of course, those are only the kind of cold outcome figures, and we're also very interested in things like women's experience of birth, and we know from the birth trauma report and so on. Okay, so what did we actually do? Well, we did an integrative review method, and the reason we chose this method was to look at quantitative, qualitative research and also policy and discussion papers, so we could take a really broad view. We looked at 16 papers, 2000 to 2025. Our study is about the UK, but we did incorporate some literature from other parts of the world to help us shed light on what's happening here. And the other sort of unique thing about this review was that we took this quite broad scope. So we were looking at clinical outcomes, but we were also looking at what some of the assumptions that the antenatal risk assessment and classification is based on, and the impacts that those risk assessments were having on women's autonomy, on women's emotions, and women's care experiences. So what did we find? Well, these are some of the challenges. Many antenatal risk assessments do not actually meet the criteria that I mentioned earlier for reliable early detection and effective intervention. So where is the sort of chain breaking down? What's the problem? What's happening here? Well, partly there's poor positive predictive value. So it's not always that easy to say, okay, if you've got this condition, you're probably going to have that thing. There's poor sensitivity and poor specificity. So we're getting a lot of false positives, which accounts for that high intervention rate with the not quite commensurate improvement in outcomes. The treatments often lack efficacy. So the available intervention for that condition does not always help the thing it's supposed to help. So just a couple of examples. Actually, last week I was at a really interesting webinar about the revised Tommy's guidelines for reduced fetal movements, and they were also acknowledging that lack of specificity. And then some of the studies in our study, some of the things, literature we looked at in our study was also talking about fetal movement as a predictor for perinatal morbidity and mortality, and that it wasn't particularly precise. Another example is fetal growth scans being predictive of shoulder dystocia. It's not a very good predictor. So that's that kind of first bit of the poor predictive value. And then thinking about the treatments, things like, for example, high BMI. Some of the care pathways that women with high BMIs are put on don't necessarily actually improve the outcomes for those mothers and babies. Another example being induction of labour or planned caesareans after a scan's finding of large predates fetus. They're also not really having the outcomes that the intervention was kind of promising. And the final problem I want to mention here is this population data versus individual care. I think this is really interesting, and we come back to it a little bit later. But using population data as deterministic for that individual can neglect the personal history, the values, and also the protective factors, the health factors of that woman. So epidemiology has got quite poor predictive value for the individual. It's very good for predicting where you need NHS funding, for predicting how much equipment you need, for being able to look on a population level as to whether interventions like smoking interventions or something are having a population-wide outcome. But when you've got a woman sitting in front of you and you're saying on a population-wide basis you fall into this category, it's not always a very good way of making a kind of prediction for her as to whether she would benefit from that intervention or that specific care pathway. So some of the effects of this risk-orientated assessments and care pathways, well, partly is the iatrogenic harm risk. So medical interventions such as induction and caesarean sections can cause harm, including to the neonates, like prematurity, low birth weight, or risk for subsequent pregnancies. There was a really interesting, one of the studies we looked at was this Breeze and Lee's, two obstetricians actually, it's reasonably old now, it's 2007. but they looked at fetal growth restriction screening and were talking and did a sort of quantitative analysis that some of those babies would have fared better in utero. They were sort of saying, is the intervention we're doing actually causing iatrogenic birth weight? And of course, an induction of labour at 37 or 38 weeks, well, that particular fetus might well have wanted another 2, 3, even 4 weeks in utero. And then recently, actually just, I think last week or something, the ARCUS 2006 study came out looking at some more data of the design trial, 2002, which has very similar things, that the fetal growth restriction screening isn't particularly good at predicting which babies would do better with intervention. Actually, I've got a whole slide on that because it's very interesting. So cycles of intervention. So the other thing that's happening is that the risk assessment itself can lead to over-referral and intervention, equating doing more with increased safety. So one of the findings from Clark was that assessments for reduced fetal movements increased the likelihood of intervention, even if no concerns were found. So the woman comes in, has scanned, but somehow along the line, when you looked at the numbers, the act of coming in for assessment increased the probability of an intervention. And then from that Tommy's webinar, actually, they said 40% of women attend at some point in their pregnancy for reduced fetal movement. So that's quite significant if that is increasing the intervention rates, just the act of coming in. And that's one example, but quite often there was studies that were talking about the impact of the risk assessment process itself. So I just want to do this as a kind of example of where the chain breaks down. So this is taking the example of induction of labour of large for dates. At every chain in this, maternal anxiety is going up, loss of confidence is going up. So the first stage would be the midwife measuring with her tape measure the census bundle height. Well, this was originally designed for small gestational age. It's now used for large gestational age. We know there's practitioner variation in this. Some midwives, particularly kind of old school independent midwives, would prefer to just use their hands and feel that fetus. So it's not a particularly good predictor anyway because of variation and because women come in different shapes and sizes. And I think, those of us that are practicing midwives on the call will recognise that you measure, but you think, yeah, but this is a small woman. Okay. Then they sent for the scan. The scans, we know, have a 15 to 20% margin of error. So there you have the sort of first link in the chain, your test with the poor predictive value. Then you go on to your intervention, induction of labour. Well, induction of labour itself is a risk factor for shoulder dystocia, for labour dystocia, and for slow progress. So the thing that you were hoping to treat, you might also be introducing another risk of that. And then you have your possible iatrogenic harm. So you've got possibly a premature fetus for that fetus, even if it's, say, 38 weeks. That particular fetus might not have been expecting to be born for a few more weeks. And of course, we know that induction of labour is a very different experience than spontaneous onset labour for women. And I think we're all aware of the birth trauma report that came out recently too. So a quote from the Big Baby trial, a limitation was poor predictive value of scan estimated fetal weight for large gestational age at birth. Only 40% of participants in the standard care group and 42% in the induction group had a baby with a birth weight higher than 90th centile. So of all the babies that were classified as large gestational age and possibly offered induction, there was a 60% false positive. It's a lot. So ultrasound for small for gestational age, like I was mentioning, the design trial, so good high-powered study, and their conclusions was the performance of late third trimester ultrasound estimation of fetal size to detect small for gestational age is poor. This is ARCUS et al., which have done a sort of secondary analysis on the design trial, looking specifically at when the scans are done and the time between the scan and the birth. They say sensitivity was low, especially if there's longer between the scan and the birth, as low as 4% in some categories. And they conclude, although I've paraphrased a bit where the italics are, when ultrasound estimation of fetal size is used to inform clinical management and prompt closer surveillance, we must be careful to reduce the risk of perinatal mortality without added neonatal morbidity associated with false positive results and the timing of iatrogenic birth. So they're really recognizing that you've got a balancing act there, which I talk about a bit in a second. So another really significant thing, which I mentioned earlier about the risk assessment and classification, is that it can limit women's choices and funnel them into predetermined care pathways. The focus on surveillance and delivery method can preclude beneficial experiences, care, and outcomes. And here I'm really thinking about what we know about midwifery continuity of carer and what we know about midwifery-led birth settings. So the high-risk classification often excludes women from midwifery-led care and birth settings. So if we think about that large for gestational age baby, if it is on the large side, one might argue that spontaneous onset, where the pelvis, the ligaments have really had time to soften, the fetal head has really had time to come very naturally and gently down the birth canal and get in the absolute optimal position, that there's maximum oxytocin in the woman's body, that there's slow, that she's not rushed, so she can really kind of be moving with that baby, and maximum mobilization, use of water. One could argue that that would be particularly important in those circumstances. And we know that an induction of labour isn't that, but it's forcing the uterus to contract. Maybe the head's engaged, but maybe it hasn't done that those very subtle movements, which can cause those complications of the head coming through the birth canal. So I think taking interventions which restrict just on paper, they say you're high risk, therefore you're not eligible for this midwife-led birth setting, when we already have the evidence from birthplace study, from Hutton et al., from Scarf et al., of benefits of birthplace, of midwife-led birth settings and of midwifery continuity of care throughout the pregnancy and birth journey. So the other thing one of the studies looked at was the emotional impact of the high-risk label. One of the studies, the Stahl and Huntley, looked at that specifically. That's what their research was about the psychosocial impact of the risk label, and unsurprisingly they found that there was some anxiety and loss of confidence, although it wasn't actually as conclusive as you might think. It's an interesting study to read, but overall it definitely had that impact. And then the moral and social pressures. So we've got this system where we've got these antenatal risk assessments and pathways which don't deliver quite exactly what they are promising to do. Nevertheless, there is a big pressure to comply with the antenatal risk assessment and classification and comply with the interventions. And I would argue especially those experiencing social or racial inequalities maybe feel that they want to prove that they're good mothers, that they're good patients, that this doing what's best for the baby. If you've been advised to have this extra scan, these extra tests, these extra glucose tolerance tests, and that's what you want to do the best for the baby. All women want to do what's best for the baby. So when it's presented that way, there is, and often, in fact, it's not really presented as a choice. It's said, I'll just book you in for the scan, or I'll just do this blood test, or we're just going to monitor baby in this way. It's not really presented like, we could do this test. It will tell us this. It has this much margin of error. And if we have a positive finding, this would be our possible interventions or possible care pathways, which themselves are effective in X number of cases. So just to emphasize this point about the balance of risk, one finding that really repeated through most of the literature we looked at was this insufficient information about the balance of risk to women. So when you're talking to women, when midwives are talking to women, they present the risk that they found and the intervention, but they're not really talking about like a balance. So to take the cesarean section subsequent to reduced fetal movements as an example, we could assume that if you have a woman presents with reduced fetal movements and goes on to have a cesarean, you may have lowered the risk, the very small risk of a unexpected intrauterine death. You've brought that risk down. You go straight, she's coming with reduced fetal movements, you do the cesarean, baby comes out. You haven't sent her home with reduced fetal movements. Good. What you've also done, as we know, as professionals, is you've increased postnatal complications, cesareans and operation. That you've increased postnatal complications without a doubt. You've also increased subsequent pregnancy complications, including the risk of stillbirth in subsequent pregnancies. So what we found was that the strength of evidence and the balance of risks of the intervention versus the problem it was intended to mitigate were not usually explained to women. There was an over-assumption, including by midwives and other healthcare professionals, of the link between the risk classification and the care pathway to mitigate that risk, regardless of how remote the possibility of the risk, nor how likely or severe the effects of the cure. There's a kind of, we found this, so we'll do that. It's kind of all wrapped up in one sentence almost. So, yeah, just about that sort of top chart, the AFFIRM trial did show, I think I've mentioned that already, that caesarean section does go up with reporting of reduced fetal movements, but all recent studies does not show conclusive evidence of those C-sections reducing stillbirth. That's also from the webinar I was at last week, at the Tommy's one. So it's hard to know, really, if the increase in anxiety and the increase in those complications is overall making the positive difference we make. And I think my argument would be really that this is the kind of stuff we need to be talking to women about. So, moving on to that, what would a better risk assessment process look like? So this is really what we started to look at, is say, okay, we've got these criticisms, but as we know, some women have risk factors. We want to give good care to everybody. So what would we imagine a good risk assessment process would be like? Partly, I'm sure a lot of people on this call are, very aware, midwifery, continuity of carer, consistently shows good outcome. There's this thing about, if it was a drug, it would be unethical to not prescribe it. We know it reduces interventions, it improves experiences, it enhances safety for women, especially those marginalised by society. We've got the Sandel et al. Cochrane review, which is, was the same 2017, whenever it was the first one, and then the more recent one, Roebuck et al. This Fernandez Tunezo, there you go, my turn to mispronounce surnames. So this was the continuity of carer in area of high social deprivation. It found that preterm birth reduced by 34% with midwifery continuity of carer. I mean, this is an astounding statistic, Well-being. So yeah, partly midwifery continuity of carer, we can't say it often enough. Well-being. So relational approaches, which would come as part of continuity of carer, balance physical safety with psychological well-being, with health factors, as well as looking at risk factors, with autonomy and respect. Oh, the other thing I just want to mention actually about midwifery continuity of carer is that, sorry, I just saw that Tommy's webinar was really good. I know I keep referring to it, but it was really good. But one of the things they said is that in terms of reduced fetal movements, they acknowledge that women's intuition is a really significant predictor. So one can assume that if you have midwifery of continuity of carer, that intuition is going to be taken more seriously. If you say to your known named midwife who's seen you, I've just got a feeling, of course she's going to listen to you in a different way from arriving at their assessment unit or arriving in triage, saying, I've got a feeling, but they don't know you. They do all the checks. They say everything's fine, looks all right on paper. And I think that we can sort of intuitively see that women's intuition is more likely to have more weight in a midwifery continuity of care setting. Finally, social support. Not finally for what we should do, actually, I've got a second slide on that, but finally for this slide. Well, social and economic factors affect outcomes. We know this. But the response has been more surveillance, more scans, more tests, rather than addressing the structural inequalities. You could imagine that if you know that women from economically deprived backgrounds have worse outcomes, you could fund community centres, you could fund good childcare for their toddlers, you could fund healthy eating projects, you could fund, more intensive midwifery care with group work there. and maybe that would have also some impact on those outcomes. I think that knee-jerk reaction that surveillance is risk assessment intervention is what we do is kind of putting the cart before the horse sometimes as well, rather than actually looking at what that risk factor is and thinking, well, could we actually mitigate the risk factor itself if for example, poverty is one of them. So drilling down a bit into what the actual, in sort of practice, what the risk assessment might look like. Well, we know from all the reviews, from Ockenden, from Kirkup, I'm sure Baroness Amos will say the same, women being listened to, that is always there. So listening to women. Risk assessment being an ongoing, context-sensitive conversation between a woman and her midwife, reviewed, taking her views into account. Trust and unconditional support for decision-making empowers women as protagonists in their pregnancy, supported with clinical expertise and evidence. And this is what I mean about being honest about those, honest about the predictive value of the tests, honest about the efficacy of the treatment, honesty about what we know and what we don't know. This, when women are told, oh, you're high risk for this, they're not really told how sure we are that that means they'll have this outcome. For example, things like large baby for shoulder dystocia, it's not particularly predictive, actually. Not that that woman might then not choose to do something, but we've got to be honest with them when they can weigh up their decisions, and we support them to weigh up those decisions with the information. So the risk of the assessments and the treatment pathways has to be in there too. We can do this intervention, it has these risks. We can do this test. There's a high rate of false positives. Do you want to do the test or not? It's okay to ask them that. So, for example, the risk of, for example, hospital-acquired infection, the risk of induction of labour, or the risk for subsequent pregnancies might be more salient for some women than for others. A young woman who expects to go on to have a big family, maybe she's from a culture where they often have big families, for her, that caesarean section decision weighs very differently from the 41-year-old IVF pregnancy who may go on to have none or maybe one other baby. And that is in the relationship, that is in the weighing up, that is in the kind of decision making, and for every one of those decisions, the woman will have her own values and her own particular weight to bear on that, and her own decision as to whether she wants to go ahead for that risk assessment, and if with the knowledge that if it's found positive, she can also have choices as to whether to go ahead with that care pathway. That is the end of my presentation. What's that? Yes, I'm good for time. So that is my contact details. I love this topic. I can talk about antenatal risk assessment all day, so please do, if you're interested, get in touch with me. And then, like I say, on the references, I think if you want to have a look at these slides and the references, they're not really all the references are in the paper, but I've just added in a few, either because I've specifically mentioned them or because they've come out subsequent to the publication. Thank you. So that's me, over and out.
Fabulous, Anna. That's fabulous. That's really, I mean, it's so interesting. It's really so interesting that we spend all our time and effort doing our best, but not realizing that we're not getting it quite right and we could be doing it differently. And sort of thinking about your discussion on focus on factors like looking at poverty and making sure women are getting those women are getting healthy eating rather than early induction or whatever. I thought it was really interesting. Now, for those of you who are listening or watching, remember all of those references that Anna had on the slides are in the resource sheet. And if you look at Anna's paper, there'll be even more references in there that you can access if you're.
It's all in there, really. Yeah, just
exactly. So this is to sort of, and I have to say, I love when the researcher comes to talk about what they've been doing, because it all comes alive. And some papers can be very dull. This wasn't dull at all. And certainly the kind of focus on the continuity of care And the idea of the Fernandez research and the reduction, was it 40% or 30%?
34%, 34% reduction
34%.
in
Now you
preterm
see.
birth. I mean, I find that mechanism fascinating as to why we always find that continuity of care and preterm birth, but especially in areas of high deprivation.
And really, I mean, it's quite astounding. And I know whenever I listen to people like Mary Renfrew or Jane Sandel herself, you kind of think, well, it must cost less in the long run. Because, I mean, for example, the preterm birth, babies who are in neonatal intensive care or neonatal care are going to be quite costly little souls. Apart from, and that's just the cost of the care. It's not the human cost of that mum having to cope with the anxiety because she's been anxious during her pregnancy, and then she's got to be anxious with her new baby. Now, the other thing is, folk, if you've got some questions for Anna, this is your chance. I've got one comment from Belinda Hill. Hi, Belinda. And Belinda says, I think that the confidence of a midwife to present that balanced information and choices comes with experience and confidence in the practice. Absolutely, Belinda. You also need all this, and hopefully from Anna's presentation, you've got some of the kind of grip of some of the things you can think about for your antenatal questions and the choices that we do give, because I agree, we do have a package of care, and sometimes we don't think about, well, what does the woman actually think? What does she understand about what's being said? And I was thinking, I mean, I've got so many things scribbled down, Anna, you wouldn't believe.
I'll just mention something else while you're.
When you were talking, yes, please do. While I'm mumbling, go on then, Anna.
No, I just realised that in all of it, I didn't mention the Tommy's Clinical Decision-Making Support Tool, which is what's it's being sort of piloted at the moment. But just when you were talking about cost, like what they've got is a kind of algorithm which makes a more specific risk factor for that woman and does take some health factors into account. But one of they're really hoping that if they can narrow it down to the women that really need it, that they can reduce the intervention and the cost for the larger number that don't. So they're hoping it will reduce hospital admissions by being able to be more targeted and specific. That's one of their kind of goals in that. And I think it does have some promise for as a more sort of specific to try and move away from that, what I was saying about that sort of population-wide data where you kind of get a tick box.
Yeah.
And they're trying to kind of narrow that or refine that a bit.
Okay, so we need to go along to the Tommy's website, which is not on your resources, but you can find it quite easily.
It's in the references of the main paper, though. Tommy's Clinical Decision Support Tool.
Fabulous. There you are. It's all there. Now, Belinda Hill was having another comment or question, and she says, is that continuity antenatal, intrapartum and postnatal? Do you have to have the continuity of care all the way through?
I don't know I don't know off the top of my head what the Fernandez-Torino study was looking at. But I would assume that when we say midwifery continuity of care in the sort of definition of the Sandel et al. Reviews, that you would have it intrapartum as well, I would expect. I don't know. And that's not what better birth's definition is, though, necessarily, is it? They also have team midwifery. But I think we're really looking at midwifery continuity of care rather than midwifery continuity of care teams that make the difference. It's knowing your midwife and knowing her name.
Yeah. Well, I mean, it always astounds me because when you think about, you go to your dentist, I don't have a different dentist each time. If you go to the hairdresser, you don't have a different one each time. You have the same person. We should be able to do the same for women and their families. Now, I just need to also do a kind of a shout out to people who are coming in by Qatar and Turkey. Hello. Some newer people here. And just to say, when I'm looking away, please forgive me, I'm looking at my other screen to get the questions. Now, Gillian Meldrum, hi Gillian, is saying, what reaction have you had from the community that promotes increased surveillance and consequent intervention? Has it been well received? That's a brilliant question, Gillian.
That is a really good question. I mean, yes, there's our can of worms, isn't it? I mean, to be honest with you, it came out about a month ago or something. I mean, it's been really well received. I've had loads of really, really positive comments on LinkedIn and on my email and stuff like that. So most of the sort of midwifery community have really welcomed it, and I think partly because we're actually trying to drill down into the sort of outcomes and things as well. I haven't yet seen that pushback, which I know that you're referring to, and I think we're all aware of. So maybe just because I haven't come on their radar yet. So, but the figures are the figures, and I think myself and my co-authors, in no way are we against intervention, or undoubtedly we are saving babies' lives. UK maternity care is some of the safest in the world. It still is. It's just that we're also having a kind of crisis of over-intervention. And I think once you get to 47% caesarean section rate without really the same significant drop in or improvement in neonatal outcomes, you have to ask these questions, really. I think that Andrew Week's paper that came out about 6 months ago, looking at that very sort of complex mapping of what's actually happening with that over-intervention, is really useful contribution there as well. But I think this kind of zooming out and saying, hold on a minute, what are the assumptions that we're making here? Because I think there is that community that equate more intervention with more safety. I think we're all kind of aware that is a strong tendency in some of the debates around maternity care. And I think to be able to kind of to stop and say, well, hold on a minute, obviously if a baby's in trouble and needs to get out, we're all for that. But what are the assumptions we're making along the line, and where is the chain breaking down? Because it's the fact of the matter is that we're up to almost 50% caesarean section rate, and we're not seeing those improvements. So there's a gap somewhere, which is where we started really our questions.
So something's not adding up. I have jotted down, it's interesting because everyone is very, and especially within the media, there's a real heightened awareness of risk, and there's a heightened awareness that we've got to have safety at all costs, and you've pinpointed that it's not adding up.
It's not, but I think this is the important thing, is that safety is a different concept from just risk assessment. And that's what I mean about safety in terms of the woman being listened to, the woman making her own choices, the midwife-mother relationship, listening to the woman's intuition, her psychological, her social safety, which we know actually improves outcomes. Certainly postnatally, a confident mother will go on to, breastfeeding rates are higher, for example. So, those proposals at the end about women-centered relational care, I would argue, are actually safety measures on a clinical kind of outcome and a psychosocial level. I think that possibly when you look at those maternal direct deaths getting worse, and it'd be interesting to look at some of the maternal outcomes like, postnatal infections, some of the sort of, other outcomes, my guess is it must be with those increasing rates of intervention that you're getting that. And I think that's what we're seeing, that like the Centre Accreta example I gave, when you've got a 47% caesarean section rate, you are going to have placenta accreta, you're going to have uterine ruptures, you're going to have placenta previa. We know these are risk factors of caesarean section. So even on a safety level, in a sense, the actions, the current tendency is not a move towards safety, I would argue.
No. And I think we are also, sending women and babies home very quickly after caesarean section, when it's a big operation, isn't it? So physically, you've got the physical and emotional kind of impact of that. Someone trying to get to grips with that. That's great, thank you. Now we've got Gillian again. Gillian Meldrum has just clarified this after the understanding. Now she's got midwives need. Gillian, you're putting a lot of comments down here. Gillian was asking about the Tommy's tool, including consideration of the women's values. Is it on your radar?
Yes, I mean, it's the pilot version. They've looked at things like in their own study. It's in there's references for that, but I've read it. I'm not inside that group, but I've read their stuff, and they do look at whether women like the tool, whether they understand it, whether it helps them know when to self-refer. They have looked at they've done some qualitative research on women's views of using the tool, but I think possibly they don't take the kind of approach that I was outlining, where they're really engaged in that, where the midwives were using the tool. But it's not really what it's kind of for. It's for risk assessing for preterm birth, stillbirth, and preeclampsia. So it's rather than saying, are you or aren't you at risk of preeclampsia, it's trying to narrow the group of women who really would be at risk of preeclampsia and kind of excluding the noise a bit. So it's not necessarily, it's meant to be like a tool or an aid in that process. It's not, the idea isn't to replace the midwife-mother relationship in terms of helping the woman make those decisions. But I think there's a valid point there that sometimes they assume that if A, then B. If you are, then this is the pathway. And I think one also has to kind of question that. It might be the pathway for some women, or for some women, having their home birth might be so important that actually they've decided not to accept that. You know, we don't know what that woman's particular history is. Maybe she's particularly anxious about that condition because her sister had it, and even though she's low risk, she does want to have the intervention. I mean, those are the conversations you have to have.
Yeah, and you need a person for that. Really, thank you. That's lovely. And then we've got Gillian again. Midwives need training to understand the evidence for and against monitoring and interventions, and also training to have the conversations which you just talked about.
Yeah.
To explore women's preferences and help them to weigh up the options. That's grand. That's grand. And Liz, hello Liz. She says, "Hi Anna, one of your students here doing my PEMP on antenatal care and found this very helpful this evening, and we'll be getting lost in your references this evening, I'm sure."
Right.
Oh, I think you're going to have great fun digging through them. Well done, Liz. And we have another comment from Belinda. In the area of North Somerset where I work, women receive consistent antenatal and postnatal continuity of midwife, and this certainly improves women's satisfaction with the service. That's fabulous to hear. Thank you, Belinda. Yeah. Fantastic. And then Gillian is finishing off, I think, saying, love what you said about safety, including social and emotional aspects of safety. No, that's grand. That's smashing. Okay. And I'm just checking, make sure I haven't missed anything. Okay. If anyone wants another question, we've got one question left. We might have. And actually, when you were talking earlier and talking about the way we put women through anxiety through the process of doing these kind of assessments of risk, I was thinking there is research on the impact of anxiety on the fetus, though probably not as much as there needs to be, and we probably need to take that into account. But doesn't it mean, though, we as midwives, or does it mean, Anna, that we as midwives need to know all this research quite a lot to understand what choices we're giving women?
I think that's a really interesting and tricky question, because that's a hard ask to know. But I think if you're doing something like referring someone for something significant, like an induction of labour at 38 weeks, which in my mind is a very significant intervention, you should have some idea of the strength of evidence that's based on, actually. Yes, I think you can't know. We've just started in my team at UWE, we've just started another research project, actually kind of drilling down into the strength of evidence in a random selection of risk categories. And, you know, to go back and unpick the evidence for each one is very difficult. But I think induction of labour for post-dates, induction of labour for large baby, yes, I think you should have some idea of the strength of evidence that it's based on. And I think when you send a woman for a scan at 34 weeks because she's measuring large, you should have a rough idea that scans aren't particularly accurate, that she may well be offered something like induction, which itself has a risk of shoulder dystocia. I think that's part of a balanced conversation, and say, you know, it's also the case that, you know, your baby might be big, and this is the reason we're worried about that. Might be, you know, might cause a birth complication. You know, not to kind of gloss over those things, but to have an honest conversation. Yeah, I think we should have not every can't, I used to, when I was a community midwife, have little cards though with some of the key statistics, like the rate of stillbirth goes up with each week. So to avoid things like it doubles the risk of stillbirth, but to be able to actually say, for low-risk women, your rate of stillbirth, unexpected stillbirth at 40 weeks, 41 weeks, 42 weeks is this, and have that. And I think you should have that information at hand if you're going to be booking women for induction of labour at 41 weeks. Yeah.
Do you know what I'm thinking is, Anna, I'd like those cards.
Yeah, maybe that's.
But I guess
they
that,
change though. The stats change.
Absolutely. No, I mean, I think this is what's lovely when you have someone like Anna talking. You think actually this is a really good. This is something that we all do. We all have our own little toolkit of things, of knowledge in our mind. And I think what you have to avoid is having a sort of a script for every single thing without thinking it through what you're saying to that woman. And just every now and then stepping back and thinking, well, would she understand? Does she understand it? Asking her. But also having some key facts, some key resources that you can refer the woman to, because there are some women who want to know more information. They might, be given some and want a little more. Now I'm getting a comment. Oh, Gillian again. Thank you, Gillian. This is a comment.
Keeping the conversation going. Yeah.
I hope you'll be able to contribute to the next update of nice antenatal guidelines, care guidelines.
Yeah.
That's what she's saying. Good. And Alison, let's finish with this one. So no more questions. This is the last one. Alison Arrowsmith is wanting to say, what's next for you, Anna? And I think she means research. I'm not sure.
Yeah. So, glass of red wine. No. So we're looking in our team at UWE. We want to do a bit more research on specific antenatal research, risk assessments and their evidence base. I myself do actually want to look at the Tommy stuff in terms of how it fits with the midwifery model of care. That's actually what I want to go on to research, hopefully as a doctorate. If I ever get funding, is to look at in what way kind of more specific tool, particularly one with this sort of high-tech algorithm, how can that really be integrated into what we know is best practice in terms of the midwifery model of care and what I was talking about relational care, about having those value conversations, and how we kind of bring the benefit of both together, really, how we can use something which I think does have a lot of value in a more highly specific. We have to get away from this low specificity tools with these high rates of false positives. That is definitely one of the problems, and I think this tool offers us a more specific tool which would reduce the number of false positives and hopefully reduce the number of false negatives too, and pick up the women who really need that care. And in terms of kind of clinical outcomes, that's vital. But how do we also then use that and harness that in what's absolutely proven to be not only effective outcomes, but so important to women, is that in that midwifery model of care, in that relational care.
Fantastic. Well, you heard it here first, guys. Anna, thank you so much. Now, I always say,
Really,
and I'll say again, this is the fastest hour in the week. It's always the quickest hour. But thank you so much for coming along and sharing your research. I think we might have to invite you again.
Sue, for the invite.
You might have to come again. I also want to say thank you to Angela, who's in the background, making sure this is all recorded. So for those of you who are listening, this will come out as a podcast on Friday at 6 o'clock in the morning. Or it'll be also as a link in the newsletter. If you haven't subscribed yet, it's worth doing so. It's free. The Maternity and Midwifery Forum newsletter, which comes out on a Thursday. So it'll be there. Now, next week, now I'm away and I'm somewhere I don't get very good IT. So we're doing a little, we're having Maeve O'Connell, who's been on the show before, from the University of Cork, and she's going to be talking about some of the complexities around fear of childbirth and fear of systems. So there are some similarities and some links. So I hope you'll be able to drop in to watch that, same place, same time next week, and take care of yourselves, and we'll see you soon. Take care. Thanks, Anna.
Thank you. Bye.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's a real trailblazer. And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
That it's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution.